how I see the Indian population or population from the Indian subcontinent in London. If you move on the tube, or probably you call it metro here, if you move from the central London to the East London, what you see is each tube stop represents nearly 1 year of life expectancy lost. And do you know why? Because as you move from central London towards East London, you move from a white population to a predominantly Indian population. That tells a very big story, that even the Indian population in London or in even US have the same problem. If you look at the scale of the problem, about more than 2/3 of MI and half of CVAs are younger than 55 years of age. 70% of cases of MI and CVA have diabetes and hypertension. And MI is 6 times more common in diabetics as compared to non-diabetics. So my job this evening is to convince you that we have a major problem called epidemic. What I mean by epidemic, that when you get an epidemic, think about an H1N1 for that matter, an influenza virus. We need to devise special way to tackle it. Treating only 1 or 2 cases or 3 cases or cases is not really going to solve the problem. We need to do something to prevent it happening. That means we need to go to the core and bottom of it. So my job today is to convince you guys that there is an epidemic happening, epidemic of premature coronary artery disease. If I compare this problem of what we call vascular disease, means vascular disease of brain called stroke, or myocardial infarctions of the heart, or chronic renal failure, then we quickly see that the commonest age of vascular disease in USA is about 65 years or over. In UK is about 75 years. But in India is 52 to be precise. 50% of all MIs in India happen below the age of 50 years. And 25% of all MIs happen below the age of 40. That means in their 30s. And that's a very big problem. Recently, about 2 years ago, American College of Cardiology established a very big study to look at the scale of problem called Pinnacle Study. And it's reporting ongoing. You can clearly see the numbers at the moment. It's an outpatient-based study. And the numbers are frightening, simply frightening. This is a real photomicrograph of a coronary artery cross-section, which clearly shows that the lumen is reduced to a very small, really slit. And the majority of the lumen is occupied by a plaque. And the plaque has a central lipid core, and you can see some hemorrhage within it as well. This is what happens to brain, which goes into a big infarct. Thrombosis causes the occlusion of a major artery, causing infarction in the territory supplied by it. In the eyes, you develop hemorrhages, you develop exudates, you develop ultimately blindness. In the lungs and heart, the patient can go into acute left ventricular failure. It's an aneurysm in one of the cerebral arteries about to burst. There's a hemorrhage into the brain. And a kidney becomes small, causing chronic renal failure. So why do people die? People die mainly of 2 problems. Either a damage to their DNA causing cancer, or vascular disease causing strokes, myocardial infarctions, and chronic renal failure. Even if I look at patients who come to the hospital with acute coronary syndrome, it becomes very, very, very clear that 85% of the deaths due to coronary artery disease actually are happening at 1 year. So 1 year mortality is 14.8%. And this mortality doubles within 1 year of discharge from the hospital. So even if you look at secondary prevention, we have a massive unmet need. Why do we have this problem? Clearly, we have something called risk factors. Even if we look at the hospital, and we quickly see this cumulative incidence of all-cause mortality, and we divide them into diabetics versus non-diabetics. So the mortality in diabetes is double. So diabetes does something to you or to patients with ACS that their mortality is double as compared to non-diabetics. And the same is true for ST elevation MI or non-ST elevation MI. If you look at the cholesterol problem, we know that higher is your cholesterol, higher is your mortality. So on the right side of your screen is a total cholesterol of 6.7, which is relatively high. If you look at the middle column, which is slightly lower total cholesterol. But if you go further low, your mortality is lower. But if we make a change into the left side column, and that change is only low HDL, the total cholesterol remains low. The mortality is as high total cholesterol or LDL. If we make a further change to it, if that patient becomes diabetic, so what we have seen that the total cholesterol is low, the LDL is low, but the HDL is low, and the patient is diabetic. So this combination of type 2 diabetes with low HDL, well, I would like to clarify that we can say now that the function of the HDL is deranged rather than low HDL. That's something to you that your mortality goes very high. And I will not go into the details of what it does, but I can say that these two things, diabetes and low HDL, or a ratio of ApoA1 to B, makes your coronary arteries highly inflamed. If we look at all ST elevation myocardial infarctions coming to the hospital, we quickly realize that up to 40% of patients do not have significant coronary artery disease. What I mean to say, that they do not have the narrowings in the coronary arteries of 50% or more. Can you imagine 40% patients, up to 40%, but they're still having a myocardial infarction? You may have a simple plaque, simple only a minute plaque in the coronary artery, which can become inflamed. The lining can rupture or fissure, platelets can stick to it, causing thrombosis and myocardial infarction. We do not have an answer to it at the moment. So we have a massive unmet need. Why do people die in diabetes? Do they die of blood sugar? No, they don't. They die of vascular disease, heart attacks, strokes, and renal failure. But how do we tackle type 2 diabetes? You must get your HbA1c low. Does that translate into saving patients' life? The answer is no. If I look at type 2 diabetic patients who have never had any heart attacks in the past, and we look at their risk of having a heart attack, is the same as a non-diabetic person with a previous heart attack. It's the same risk. And that's why we call type 2 diabetics as heart attack equivalent. And that's why it's mandatory in UK to treat all type 2 diabetics as if they have had a heart attack in the past. So that means they have to be prescribed all medications for secondary prevention. If we look at patients coming to the hospital with ACS or myocardial infarction who were not known diabetics, but when we look at their admission blood sugar, it becomes very clear that their mortality depends on the level of blood sugar at the time of admission. So that brings us to this very important slide of inter-heart study, that there are modifiable risk factors, and it's very important to understand that inter-heart study looked at all modifiable risk factors. And we'll come to it that these risk factors tend to cluster together. They like working in groups because there is strength in group. So this slide clearly shows that your CVD mortality increases with number of metabolic syndrome risk factors. This clustering of risk factors clearly happens in metabolic syndrome with only one phenotype, which is your abdominal obesity. There are lots of theories, but the most acceptable theory is that when you accumulate fat in the abdominal cavity, that fat starts seeping inside the liver. And when the liver's fat is about 10% of the total liver volume, that person starts getting into trouble. And that trouble is probably spilling of the free fatty acids, causing insulin resistance, causing problem for the heart. If we forget about any other risk factors, only look at the abdominal obesity, we clearly see the link of the abdominal obesity with the mortality, both for all-cause mortality and for cardiovascular mortality as well. I'm sure you must have heard about a name called Deepak Chopra, who is a heart guru in the US. He has written a bestseller called Killer Belly. So belly, you don't have to be overweight to have belly. And that's a clear-cut, a phenotype is Indian phenotype. That we tend to accumulate fat in the abdomen. So if we see a photograph of an Indian person and what we see only the limbs, we might say that person is slim. But when we remove the screen, we clearly see that there is a fat in the belly. The problem with this cardiovascular mortality, it is disproportionate. What I mean to say with that is 3 times higher in unskilled workers than professionals. And that's a very big problem. Therefore, more common in deprived areas. This difference has doubled in the last 20 years and is 50% higher from people from the Indian subcontinent than the rest of the population in UK. Another problem, it's a true statistics that 50% of Indian people in Birmingham have already become diabetic. 35% of people in India are type 2 diabetics. A lot of them don't know that they're diabetics. So that's the inter-heart study which showed the one risk factor which clearly related to mortality is abdominal obesity. The importance of risk factors, this is the risk of each individual risk factors. But we have seen that they cluster together. What happens when they cluster together? Your risk goes many times higher when they are together. If you look at the blood pressure alone, and the blood pressure is a real problem in India. Of course, diabetes is, but the blood pressure is a bigger problem than diabetes in India. In urban India, about 30 to 70% population is hypertensive. And rural India, about 17 to 20% population is hypertensive. If you look at the diastolic blood pressure, it becomes very clear that as your blood pressure starts rising beyond 80 millimeters, your mortality starts going up. So the real good normal blood pressure is 80 or below. We looked at it. So what happens when the population moves from villages to cities? If we look at a bushman in Africa, population which lives in bush, as the population ages, there is no effect on systolic or diastolic blood pressure in that population. It remains the same. If the same population moves to the cities, the systolic blood pressure starts going up with age, with the gap between systolic and diastolic blood pressure increasing. When you go to London and you travel in the tube, when you're standing on the platform waiting for the tube to come, you read something written on the floor called "Mind the gap" between the train and the platform. Mind the gap. And that is relevant here. We know from the population studies that higher is this gap between systolic and diastolic blood pressure, higher is your mortality. What about rule of halves for hypertension? Rule of halves is 50% patients are never diagnosed in the population. Of those, 50% are not treated. Of those, 50% not controlled. That simply means in UK only 12.5% patients are well controlled. And this statistics is more or less same everywhere in every country. ASCOT was the first trial which looked at the primary prevention trial comparing calcium channel blocker amlodipine in combination with ACE inhibitor as compared with a beta blocker diuretic combination, which was the commonest thing to do in the world at that time. And for the first time showed that ACE inhibitor amlo and calcium channel blocker combination is much better. And that's what took into account. And we know the rule of A, B, C, D. A for ACE inhibitors or ARBs, B for beta blockers, C for calcium channel blocker, D for diuretics. We know that ACE inhibitors or beta blockers work well in younger population. In my dictionary, we do not use beta blockers for treating hypertension anymore. We do not, or we avoid using diuretics. So we really are left with two drugs, ACE inhibitors or ARBs and calcium channel blockers. Are they adequate? No, they do not. We know that one of the major problems of uncontrolled hypertension is lack of efficacy of the drugs which can control the blood pressure very well. So what works? Things are which work together. And the most important thing is lifestyle, which is the most difficult to achieve. Other problem, we have a substrate or reservoir of people from whom we keep seeing patients becoming diabetics. So if you see any population in the world, about 17 to 18% of the population has what we call borderline diabetes or impaired fasting glucose or impaired glucose tolerance. And this is a reservoir from which people become patients of type 2 diabetes. We know from diabetes prevention program that if we treat these people with metformin plus minus lifestyle modification, you can prevent them becoming type 2 diabetic. This was the first trial called UKPDS. It's a combination of United Kingdom and Swedish trial, which looked at the treatment of type 2 diabetic patients. The conventional treatment that bring their HbA1c low. So they took a group of people, about more than 10,000, divided them into two groups. One with intensive blood glucose control, means their HbA1c has to be brought down to the 7 or below, and one is usual treatment. In both groups, no difference in mortality over 10 years. So what I meant to say, that intensive blood glucose control really does not dent the mortality due to ischemic heart disease in type 2 diabetic patients. It can prevent the microvascular complications though. But if you are overzealous in type 2 diabetic patients to bring their HbA1c low, you may have increased mortality due to hypoglycemia and causing arrhythmias. So it depends really on the individual patient. So you have to individualize the treatment for HbA1c lowering. But when we took the same type 2 diabetic patients, divided them into two groups, one group was given intensive blood pressure lowering treatment, their mortality improved. So it's the blood pressure lowering and cholesterol treatment in type 2 diabetes which reduces mortality. If we look at people who are not diabetic and look at their blood glucose, we quickly know that even within the normal range, the highest blood glucose level people have the higher mortality. So what's the relationship of blood pressure really with cardiovascular mortality? Cardiovascular mortality risk doubles with each 20 over 10 millimeters increase in blood pressure. So that's independent of anything else. What happens in type 2 diabetes? Those type 2 diabetics who have hypertension have double jeopardy. So we know now that South Asian people or patients are younger, they are prone to MI at earlier age, 25% of all MIs are below the age of 40, 33% before the age of 45, and 50% before the age of 55. So they are a sicker population in the world. They're fourfold higher risk of MI as compared to Europeans. They're twofold higher mortality after an MI compared to Europeans. And that's important. Because if both the patients, Indian and white people, are given the same treatment, still the mortality in Indians are twice as compared to the white people. There's twofold high coronary artery disease incidence. South Asians, 10.7% incidence of coronary artery disease, as compared to Europeans is 5.4% only in the population. And 60% of the world disease burden is borne by Indians. Can you imagine? 60% of the total burden of cardiovascular disease is amongst Indians. So this excess burden of conventional or metabolic risk factors, or is it because of shortage of protective behavioral factors, or is it because of emerging genetic, glucose, insulin, or inflammatory markers? Remember my first statement, that up to 40% patients with ST elevation MI, when we do angiograms on them, they do not have significant coronary artery disease. This inflammation is causing the problem. Inflammation, endothelial dysfunction, low HDL or dysfunctional HDL is causing a milieu of inflammation in the arterial system, causing strokes and myocardial infarction. So we know there is an organ called brain and heart which is under attack, prematurely under attack, and it's dying. We also know that there are enemies like hypertension, diabetes, smoking. We are not able to control them. We are not able to diagnose them because it's an epidemic proportion. So we know there's an enemy which is attacking these organs, and these organs are dying, or people are dying prematurely. So how do we tackle them? Okay, for a disease like influenza, we develop vaccines to prevent it happening. So is it a concept that we can go to the bottom of the problem, which is inflammation, and develop an ideal drug, or at least a drug which can lower the inflammation? How do we know that? Because we can measure the HSCRP. HSCRP is a tool to understand the risk of these people. Because there are more than now 25, 30 studies of linking HSCRP with mortality to cardiovascular disease. We know that by reducing the inflammation, we can reduce the HSCRP. And this is conducted through NF-kappa B. I'll not go into detail it, but because the next speaker is going to deal with that. But the immediate priority to achieve highest long-term impact. And it's a concept of tackling the inflammation to achieve that. Unfortunately, is this the shape of things to come, of evolution? With the last image, a Coke in hand. So think about it and realize what the problem is, because the bigger picture may be starting at this age. Thank you.